For those of you that maybe I have not met yet, I'm Jordan Mayberry. I am a physician assistant at UT Southwestern in Dallas, Texas. I work in a general hepatology clinic in an academic-based setting. And so today we're going to talk a little bit about some non-invasive testing in the diagnosis of metabolic-associated steatohepatitis. So like I said, I'm Jordan. You can use this QR code to record your attendance to this meeting. And then also there's another QR code that will direct you to the GHAPP MASLD MASH community network, where there's a lot of resources on MASH disease state and also treatment for MASH. Alrighty, so to get started, we are going to start with a case, a patient that I'm sure many of us have seen for those of us that manage MASLD, and even those of us that maybe don't work in a hepatology clinic, but this patient is pretty typical of the patients that we see in practice. Albert is a 65-year-old male with obesity. And he's referred to a hepatology clinic because he's had elevated liver enzymes and he had an abdominal ultrasound that showed increased echogenicity consistent with steatosis of the liver. So he does not drink alcohol. He's not had alcohol since his 20s. His past medical history includes type 2 diabetes, hypertension, and hyperlipidemia. On exam, we see that he has some abdominal adiposity. Fortunately, no stigma of advanced liver disease. So we don't see any evidence of jaundice. We don't see any spider angiomata. We don't see any ascites. His BMI is 29, and then you can see his lipid panel here. His hemoglobin A1C is elevated at 7.2, and then that ALT has been elevated for at least 3 years, 1 to 2 times upper limit of normal. And we've already done kind of the basic workup for this patient. So we've done our chronic liver disease workup, and that workup was unremarkable. So all other causes of chronic liver disease have been ruled out. So we've ruled out any other chronic liver disease, and he does have these cardiometabolic risk factors: obesity, type 2 diabetes, hypertension, and hyperlipidemia. So we end up diagnosing Albert with MASH, metabolic dysfunction-associated steatotic liver disease. So once we have this diagnosis, what are our next steps? What's really important for us to do in this patient population once we've diagnosed MASLD or MASH is to determine if a patient has fibrosis, because fibrosis is a way to stratify risk in these patients. So there are some biomarkers that we can use for different ways to glean information on this patient. We can use biomarkers to evaluate fat, and those are things like the ultrasound, the quantitative techniques. We can do measure steatosis on MRI. We can do CAP on our FibroScan, and we can do MRI PDFF. Then we have markers for stiffness. So we can do things like FibroScan, the VCTE, and MRE. There are some combined tests as well where we can use blood markers and then imaging markers and do a calculation that can tell us about fibrosis. And then we have some other clinical prediction rules. So things like the FIB4 and APRI. And then we have other markers, which are serum markers and blood tests like ELF. So today we're going to be talking about these ones in gold, except for these combined rules here. So the first calculator that we'll talk about is the FIB4. The FIB4 is really great because it is a straightforward, easy technique to evaluate for fibrosis. So really all you need is the patient's age, a hepatic function, and a CBC. So we use their age, AST, ALT, and their platelet count to calculate risk or to stratify risk for fibrosis in these patients. So generally, if they have a score that's less than 1.3, we can feel pretty confident that this patient does not have advanced fibrosis. Now, if their FIB-4 score is greater than 2.67, then we have a high suspicion for fibrosis, and we should consider another more modality for evaluating for fibrosis. So FIB-4 is a really great test because it's so easy. It's often the first test that is used for risk stratification. At UT Southwestern in our EPIC system, we actually have a dot phrase for FIB-4. So as long as a patient has an updated CBC and hepatic function, you can do dot FIB-4 and it will calculate the FIB-4 for you. Now, one important thing to remember about this particular calculation is that age is a part of the calculation. And so as the patient's age gets higher, then it can skew the results of this test. So kind of the cutoff that we use is the age of 65. If the patient is greater than 65, then we change that range a little bit, and you can always Google the range change based on age. A proprietary serum marker that we can use is a test called ELF. So this is a blood test, and it uses 3 different markers that measure matrix turnover within the liver. That matrix turnover is a marker of active fibrosis development. So that's what ELF is evaluating, is matrix turnover. This is a test that can be used kind of second line after we've calculated the FIB-4, if the FIB-4 is indeterminate or if it has concern for advanced fibrosis. This is another test that could be ordered. Of course, we have to get additional blood work in order to get the ELF test. Some of the limitations with the ELF test, it can be expensive. Not all labs draw ELF, so we can order it at Quest or LabCorp. So we have to do kind of like a miscellaneous test within our clinic in order to get the ELF test. But mostly the limitation that we've experienced in clinic is that it can be expensive for the patient because insurance doesn't always cover the full test. But this is another test. The range for ELF, so if the ELF comes back 7.7 to 9.8, somewhere in that range, then there is a risk for advanced fibrosis. And so then we may consider further testing or a referral to hepatology clinic. And as that score gets higher, the specificity also gets higher. So both of those, the FIB-4 and the ELF test, are actually blood tests, right? We use hepatic function and CBC for FIB-4, and then the ELF test is a serum marker. So in addition to serum markers, we also have imaging that can be used to assess fibrosis. So we can use non-invasive tests like the FibroScan or the MRE, which we'll talk about each of those individually. But what these tests do is it measures the stiffness by measuring resistance of ultrasound wave through the liver tissue. So shear waves travel faster through a stiffer liver. And we know as liver stiffness increases, fibrosis also increases. So the stiffer the liver is, the more fibrosis there is within the liver tissue. So the difference you can see here between FibroScan, which is on the left, is that it is just a single point within the liver that we're measuring, where MRI elastography, we can measure a wider range within the liver tissue, which allows us to get real-time color stiffness within the liver. So when we talk about vibration-controlled transient elastography, the test that we have within our clinic is our FibroScan that uses this technology. It's a non-invasive way to measure liver stiffness, and it quantifies 2 different measurements within the liver. Number 1, it can quantify liver stiffness. So again, it tells us how stiff the liver is, and it can tell us about fibrosis within the liver. And then we also get a second measurement called the GHAPP score. The GHAPP score is used to quantify fat within the liver. So we can use that to correlate just how much steatosis there is within the liver tissue. So both of these markers can be really helpful when we are diagnosing and then stratifying risk for MASH, because not only are we determining is there extra fat, and if so, how much, we can also determine if there's any significant fibrosis within the liver tissue. So when we get a FibroScan within our clinic, and as providers, we take a look at the scan, or as our MAs are performing the scan, it's really important that we take these considerations into effect. Are there 10 valid measurements? So whenever doing a scan, we want to make sure that we're getting a quality scan. So we need 10 valid measurements. What is the quality of the image? So here on the right, you can see a very high quality scan. Um, and so that's what a quality scan would look like when we're taking a look at the FibroScan results. And then at what success rate were these 10 measurements obtained? So we want to make sure that we're not doing 100 measurements. We want those good quality 10 measurements to be kind of close to each other. And then, is the operator experienced? This is a test that takes a lot of practice. And so our MAs have gone through several of our providers as well have gone through an extensive training that's provided by the FibroScan company, and then have a lot of practice before they are kind of cleared to do FibroScans within the clinic. So we want to make sure that our operator is experienced. What are some of the limitations to a VCTE exam or a FibroScan? Well, we know if there's a lot of active inflammation within the liver, that can skew our results. So if the liver enzymes are elevated, we would not use a FibroScan because that could be a false elevation. All of that inflammation could be read as fibrosis. Same with cholestasis. If there's a lot of inflammation within the bile ducts, then we could get a falsely elevated test. We want to make sure that the patient is fasting for 3 to 4 hours before test, because if there's more blood flow in the liver tissue, we can also get an elevated exam. Alcohol use, as we know, alcohol can increase inflammation within the liver tissue, so that can give us a false elevation as well. Another limitation that is difficult is that if patients are morbidly obese or have a lot of central adiposity, that can make it difficult to get a good quality exam. So when we're ordering FibroScans, the cutoff in our clinic, the BMI is actually 40. So we will attempt up to 40, but we know when the BMI is greater than 35, it could possibly hinder us from getting a quality exam. And then, of course, if the patient has ascites or liver masses, that can give you a false reading as well. MRI elastography, again, this is another shear wave technology, much like the FibroScan, but we do this within the MRI machine. And it does produce this multicolor elastogram. So we're able to measure a much larger area of the liver for fibrosis and steatosis with the MR elastography. Some considerations, of course, this is an MRI test. So if a patient has any non-MRI compatible implants, this is not a great test for them. They have claustrophobia, then this may not be a good test. Hepatic congestion. Again, if there's a lot of blood flow or something that's causing congestion within the liver tissue, that could give us a false elevation. BMI, of course, if they are morbidly obese and have a very high BMI, getting in the MRI machine may be difficult. But if we are somewhere between, 35 and 45 BMI calculation, this may be a better test than FibroScan, just because the MRI can assess a much bigger area compared to FibroScan. So often in our clinic, if a patient has an elevated BMI and we're just not able to get a quality FibroScan, MRI would be the next recommendation. Now, one other limitation we are very privileged at UT Southwestern having access to MRI elastography. This is an expensive test, and not all centers have MRI elastography. But if you do have access, or if you're able to send patients over to UT Southwestern, then this is an option, but it's not an option for everyone. And then I will say that this can also be expensive. I had a patient that I saw this week that I recommended an MRI elastography because their FibroScan was elevated and it showed evidence of cirrhosis, but their FIB4 was very low. And so I said, we need a tiebreaker. I recommend an MRI elastography. And they contacted their insurance, and it was going to be about $700 to do the MRI elastography. So there can be some cost limitation to the patient. So that's something to be aware of with MRI elastography. This is just a really great kind of chart that puts all of this together. So all of the tests that we talked about this afternoon, including FIB4, ELF, VCTE, and MRE, talks about how we calculate these tests, or, kind of what modality is used, like the kilopascals, and then the rule out and rule in cutoff point. I think one thing that's important to remember with the imaging modalities, even though they're both using shear wave, the cutoff points are very different. So you can't read a FibroScan and use the same numbers that you do with an MRE. They actually have different cutoff points. So this is just kind of a good graph, or a good table to put in your white coat pocket whenever you're thinking about using these tests, and how we calculate and use these tests. So let's get back to Albert. So this is a patient that we are evaluating for the first time, and we have determined that he has MASLD, that he doesn't have any other chronic liver disease. And so what we need to do is we need to assess his fibrosis. So we start, of course, with that very straightforward calculation, the FIB4. So we have his ALT and AST, we have his platelets, and we have his age. So his FIB4 score is 2.2. So that's kind of in the indeterminate range. And so this is a great flow chart on how we should be assessing these patients. And if we aren't in the hepatology clinic, what we should do with these patients once we have calculated their fibrosis, once we've calculated something like the FIB4 or their fibrosis stage. So if they have, first we need to identify our patients that are at risk. So if they have any of these cardiometabolic risk factors, or if they have type 2 diabetes, or if they've had a recent ultrasound that shows steatosis, then we want to rule out other possible causes of liver disease. Once we've ruled out other causes and we diagnose this patient with MASLD, we'll calculate that FIB4. So his FIB4 is 2.2, which is indeterminate risk. So we send him over to the liver clinic to get a FibroScan is what we do next. So we do a FibroScan in our clinic, and his kilopascal score was 6.7. So you can see here on this flow sheet, it was less than 8. So he has low risk for fibrosis within the liver. So based on that score, we would recommend lifestyle modification. We want to try to decrease these metabolic risk factors. We want to manage his diabetes, work on weight loss, manage his hyperlipidemia. And then we would recommend repeating these non-invasive tests in 2 to 3 years based on these guidelines. Now, if he were to have a higher kilopascal score, then we may want to consider sending him to a hepatologist for further workup, especially if the kilopascal score is greater than 12. That is concerning for cirrhosis, and we want to make sure that we are managing the cirrhosis. Awesome. So pretty straightforward and quick about just some of the non-invasive tests that are available for us whenever we have our MASLD patients. Were there any questions about any of these non-invasive tests that we discussed this afternoon? or any questions about MASLD in general. Well, thank you so much for joining me this afternoon for just a quick overview on some non-invasive tests in our MASLD patients. I hope this was beneficial in how to use these tests and kind of how to incorporate them into your practice for our MASLD patients. And if any other questions come up, feel free to shoot me an email or connect with me in the MASLD network, and I'm happy to discuss any and all things MASLD.
Thanks, Jordan, and thank you all for your participation. We'll be sending some updates to Jordan's MASLD community network page, which she mentioned has a lot of resources on that. So that will be helpful to all of you and just some additional educational content. But thank you again, Jordan, and for all of your participation. And we hope you have a great rest of your day.
Awesome. Thanks, Gail.
Thank you.